Okay, great. Well, welcome everybody. Thank you for joining us for today's webinar. My name is Kim Peek. I'm with the Interior Health Research Department. And today our presentation is incorporating CCGHR principles in rural health research in BC by Kira Barwich. In this webinar, Kira will guide us through the process and progress of the building blocks for sustainable rural maternity care, a project that began as a response to inequity of maternity services for Northern Vancouver Island communities, and with an intent to understand community experiences of birth on North Vancouver Island. Kira is a research coordinator at UBC at the Centre for Rural Health Research. Kira has a Master in Science in Global Health from Trinity College, University of Dublin, and has worked on global health research projects in Indonesia, Zimbabwe, and Cambodia. Her current role involves looking at how to sustain maternity care in rural, low-resource communities in British Columbia. Before we get started, there are a few housekeeping notes I want to mention. Please be sure to mute your lines by pressing pound 6 or by pressing the little microphone thingy in front of you. That's what I have. The session should run about 50 minutes, which includes a quick introduction, presentation, and some time for questions and discussion after. We'll begin the session and sharing with you afterwards. If you have a question during the presentation, please feel free to type them into the question box in your WebEx control panel. It's actually called the chat box during the presentation, and we'll also have time for questions at the end. Started, Nicole will provide us with a brief introduction to the webinar series. Nicole is a program advisor in emergency management with the Provincial Services Health Authority and the Phase 3 coordinator for BCCI.
Hi, thanks. We're very, very grateful for your support and happy to speak with you today. A special welcome to those joining us from out of the province. I think we have 1 or 2 so far, and we might have people joining us from out of the country too. So for those of you who are not familiar with the BCCI, it's a regional model of the CCGHR that focuses on equity-centered practices for connecting knowledge to action, using the recently published CCGHR principles for global health research as a framework. So the Institute includes 3 phases. The first was an intensive phase, and please go to the next slide for me there. We have a model that shows the activities that were included in the first one, so that's readings, videos, webinars, questions. Second phase was a 3-day on-site event in Kelowna that consisted of workshops, panels, and open sessions that focused on participants' self-directed learning objectives. And then nearing the end of the third phase, that includes the capacity strengthening activities in the participating universities and regionally, including this webinar series, which is supported by our partnership with Interior Health in connecting a Canadian health system with a capacity building initiative of the CCGHR. So I'm really excited for this webinar, not only because Kira and I were both at the on-site event together, and we're both CCGHR student and young professionals, members of the newly developed community of practice, but it really brings together a lot of things that we had on and in and throughout all the phases and up to a real-world setting. So without further ado, I'll hand it over to you, Kira.
Thanks, Nicole, and thanks for hosting this. Thanks all for joining this webinar. I'm looking forward to share with you a bit about our work, due to my work, and how it aligns with CCGHR principles for global health research. So just to start, the objective for today's webinar, I want to explore the community-driven research process and its alignment with the CCGHR principles within a global local health context. And so to that, I'll start with giving a brief overview of the North Island maternity context and history. I'll describe the process that we took in the Kwakwaka'wakw territory to determine local priorities for maternity care, and then I'll present a bit on what we heard through the community process and what we're doing and what the next steps are. So I wanted to familiarize everyone with the principles, the CCGHR principles, and put them up here. So to highlight each of them throughout the presentation, but obviously it's not going to be stepwise as slides make everything stepwise. So they were all kind of interwoven throughout, but I'll be sure to kind of pause along the way and and point your attention to specific ones where I think it's more. And the next one I want to look at is responsiveness to causes of inequity. So questions relating to this are, what are the root causes of inequities related to the research issue, and what implications for responding to these causes? So this question really comes up in who the project is based around and where it was started. So I'll give a bit of background on the Kwakwaka'wakw territory in North Vancouver Island. So the region covers 21,000 square kilometers of northern Vancouver Island and the adjacent mainland, comprised of a number of isolated communities. So the current population is just over 11,000, and over 26% of the population would identify themselves as members of the Kwakwaka'wakw family. So there is one designated maternity site, which is the Port McNeill Hospital in the area. So this is a 1A maternity site, meaning that there's no local access to cesarean section. It's just a low-resource maternity site. The population in the area has a high degree of social vulnerability, represented in the high rate of teen pregnancies, single-parent families, alcohol consumption, and death from illicit drug use. Despite these known health disparities, these communities have less access to health services than populations of similar size in other parts of BC. So the lack of access to appropriate health service level is persistent. Back in 2009, the Center for Rural Health Research, with funding from First Nations and Inuit Health, engaged in a 2-year project to understand the needs of Aboriginal women in the North Island of birthing services. So from this report in 2009, recommendations included that they should have access to local midwifery care and access to local cesarean section services. However, these recommendations from 2009, nothing's changed since, and women are still leaving their communities to give birth elsewhere. So with the support of First Nations Health Authority now, 10 years later, we wanted to revisit maternity care in the North Island and understand what the community's needs were. Maybe things have changed, maybe women are happy to travel for care. We wanted to understand more. So looking back to the CCGHR principle of looking at equity, so we saw a clear lack of appropriate access to health services for the population in the Kwakwaka'wakw region. So that's what led to set this area again and looking at what the community needs and wants were. Talk about humility, another one of the principles. Questions to consider here are, who am I in this research context, and how do we position ourselves in the research? One of the definitions CCGHR uses talks about humility as positioning ourselves in a place of learning rather than knowing. And I thought this was pretty prominent, especially in the initial phases of the project. We had a posture of learning, which actually allowed the project to evolve into something different than originally was proposed in order to better reflect the community, what the community was telling us they needed. So originally, the funding was for a project to create a patient decision aid for women to help them decide, along with their care provider, if they would be better suited to deliver off-island or on-island or in their community. And so we were going to create a decision aid that took to consider the cultural impacts and the social impacts, making these decisions of where to give birth. However, when we started initially talking to the communities, we realized this, as it was not sustainable. We needed to go upstream and look at how to sustain serving the community first, because as it were, there was no real choice to be made, as there just weren't sustained local maternity services. So that the project evolved into the Building Blocks to Sustainable Rural Maternity Care project in the North Island. That was a shift in the project, and then as we continued down the road, we wanted to look at what it would take to sustain local care. So we incorporated these principles of inclusion and authentic partnering in our community-based process. So inclusion looks at how our research practices proactively promote the involvement and participation of people who are historically marginalized. And authentic partnering, how has attention to these principles informed the partnership, and how are we assessing equity in the partnership, and are we doing to foster equity in the partnership? So I'll kind of go through some of our community processes that along with these principles here. So as mentioned, We've included community members and key decision makers in our advisory committee and involved them from the very beginning and throughout the evolution of the Building Blocks project. So the committee we had for the project, it meets bi-weekly, and here we share updates, we receive feedback and comments, and collaborate with participants in the committee. Our advisory group includes representatives from Island Health, from Perinatal Services BC, from Nations Health Authority, and importantly, representatives who are moms from the North Island. I also made sure to reconnect with these community representative moms every time we were in the North Island, so we have a very strong relationship with them. We also worked with a physician representative group from the North Island, which was important as the work revolved around care provider needs to sustain care as well. So this consisted of 4 self-selected physicians who had an interest in maternity care, and they wanted to attend meetings and focus groups for the project on behalf of the physician group in the North Island. We have 124 participants. About half of these spoke from the patient perspective, so such as moms, elders, and family members, and the other half of the participants included nurses, physicians, paramedics, health center directors, and administrators, and over the course of 12 focus group discussions and 30 interviews. So we were up in the North Island often, so we had 6 community engagement trips, and we visited or involved people from 8 of the communities up on the North Island as shown on the map there. Other partnerships that emerged was a partnership with First Nations Health Authority, the Kwakwakiwak Maternal and Child Health Program. So they're also working to improve maternal child health in the region, so we worked very closely with them. An organization called Ways to Healing Partnership, which focuses on prenatal trauma-focused care for moms who are at higher risk. And so, again, we worked really closely with these organizations to ensure wraparound care for the moms and babes in the communities. And so the principle to highlight is the shared benefits. So how each partner is benefiting from the research and how the benefits are being distributed among those involved. So to start, our project is committed to the OCAP principle, so that's data ownership, control, access, and possession. Furthermore, our project relies on integrated knowledge translation throughout, so it's grounded in community-based research methodology and guided by the community through an iterative process, so that committed to bringing back what we heard from the community. We had regular communication in the form of infographics, brochures, and in-person discussions. At the suggestion of one of our community representatives, we did a community Facebook group as well to share project progress and updates with the moms. I told moms in the North Island used Facebook mostly for their communication with each other. We have a website and a blog. We provided project updates as well. We ensured our knowledge translation pieces were written and described in a way suitable for the audience. So as you can see there, there's 2 of the brightly colored building blocks ones, and one was provider facing. So the language was specific to the providers in the North Island, and the other one was community facing. So the language more specific to moms in the North Island. So we were really aware of our language and how we are communicating, and always had our phone numbers, our emails, and requests for feedback and comments to have dialogue with what we were finding and feedback from the community. What we're hearing from the community, we requested chart data from Island Health to confirm what we were hearing about women traveling for birth. So we hear that the majority of women do leave the community to give birth. So annually, there was an average of 103 pregnancies in North Island, with an average of 3 deliveries in Port Hardy Hospital, which is a non-designated maternity site, and then 4 at Port McNeill Hospital, which is the designated 1A maternity site. So the majority of mothers left their community to deliver at hospitals in Campbell River, Comox, or elsewhere in BC. Annually, we had low numbers of births in the North Island. And some of this data, the numbers are actually a bit higher because home births are not included currently in this data. So We hear moms of their experience of maternity care. Many moms do not have the any confidence or low confidence in their local maternity service. One mom said, I just feel like they aren't very attentive, and I know birthing is not their forte, so I just wouldn't feel comfortable. Many spoke of their desire for midwifery care being a reason that they would leave the North Island to give birth, as there's no local midwifery right now. Participants spoke of the informal communication within the community that shapes community perspectives on birth. So this is a reoccurring understanding that birth is not allowed in the community or is not safe. First, there was an assumption that you just don't have babies in the community. There was a narrative from moms where they told us they were considered high risk and therefore could not deliver in their community. It's well known that challenges moms face are largely logistical in terms of issues with transport, accommodation, and getting to appointments when they have to leave for care. Traveling for birth, participants spoke of their experiences of care in referral communities, heard of challenges to arrange transportation, not only to the referral community, which the closest is Campbell River, and that's 2 hours drive away on a good day, without their challenges, which are often there as well. We also heard of challenges when moms were in the community trying to get from the hospital maybe to the hotel and trying to arrange food. We also heard of the cost associated with all this and the psychosocial impact on moms, as we heard lots of experiences of loneliness, anxiety, as they are isolated in these referral communities without their community supports. Not all respondents had negative experiences. Some positive experiences of traveling for care included a sense of safety, knowing that there is an OR with C-section capabilities should something go wrong. A sense of safety knowing that it's a higher volume center where care providers are confident. And these positive experiences with healthcare providers in a referral community many times led to a referral pattern being established. So if the mom had more children afterwards, she's go back to the same provider down island or off island, wherever it was. Inevitably, hearing of women's experiences of birth in the North Island means we heard of women's experiences of transport. Participants spoke of the convenience and the cost of transport and the inclement weather conditions, which can impact the mode and the safety of the transport. So one woman says, to go, it was all right, but it was really bumpy and stuff, and my stomach was hurting. On the back, because I was having a C-section, I had to stay in the front of the bus so it wasn't so bouncy, and it hurt a lot. It was busy, and the driver was stopping places, hiking, and plus, it was hard to carry, all your and stuff that you're eating, and supplies for the baby, supplies for yourself, and then your partner too. So that highlights some of the difficulties with transport in pregnancy for some of these moms. From the moms, what they want. So we have a desire for local birth, for birth that is supported with their family and community around. And we also heard of a desire to have a restored local birth narrative back to how it used to be. So key desire for local birth came out strongly, and also emerged conditions moms want in order to consider staying in the community for local care. So this is a strong desire for midwifery care and increased support and confidence from the local maternity care providers. So one says, it would be really nice to stay home and to not have to go down and being away from home and not in your environment and you're seen, but you don't have your nest. Students also spoke of the family and local support in their birth experience and the importance of it. So many moms spoke of feelings of isolation and loneliness in having to travel for care. Moms and elders spoke of the importance of family and community when giving birth and the loss of this support when a mom has to leave her community to give birth. This family support also attributed to higher incidences of Ministry of Child and Family Development involvement. Many appear vulnerable away from their community without their local support and community support. Further, there were some instances of moms signing care agreements with the ministry to look after their other children in order to leave the community to have their newest baby. One mom says, perfect world, if we had births here, we'd have family around. There may be doula there. There may be some of the family, the very support people need, who are visiting in the hospital before, during labor, afterwards. And the hospital staff will know who some of the support people are. The ministry know who some of the support people are. narrative of historical birth in the community as well. And these are, we heard particularly from the elders, where birth in the community used to be common and celebrated. Currently, because many mothers stay to live in the community lacks a contemporary narrative of positive birth experiences. An adverse birth outcome in 2003 where a baby died in transport. So this adds to a narrative in the community that hospital is not safe and birth is not safe in the community. In talking to moms in the North Island, there was a common theme of fear of birth, where it was a scary thing. So one says, I actually believe that if we just had in our community alone 3 or 4 good births where people folks around and then they shared those stories, everyone would come running. So moms for a desire for local care. So we continued in our community-focused investigation then with care providers and administrators in the community to ask them what would it take to sustain the services so that moms felt comfortable and providers felt comfortable providing maternity care. Some of the 5 building blocks that we came up with the care providers that they need to feel supported in providing maternity care. So these are professional care teams. So currently, there's no midwives practicing on the North Island. As we previously heard, many moms left the North Island to seek midwifery care. We also heard from moms and community members of a need for this kind of professional in their community. We also know that midwives, to be sustainable in a rural setting, will need to be integrated into a strong interprofessional team. So we worked intensively with especially the local physician group to shop what it would look like to have midwives in their community, and through this workshopping created a job description to have 2 salaried midwives start. So we're in the process of our approval for these job descriptions, and that's kind of the next step for this building block. Increased provider confidence. So this centered largely around the nurses in the North Island. So we heard loudly from the nurses that they are afraid of birth. Many of the nurses are new grads and have never seen a birth in their education, so feel very uncomfortable when a pregnant mom comes in. We heard from many nurses they just don't have the volume because there are not very many births that are happening right now in the North Island. They just don't feel confident when they do come in. This building also goes with the one before with midwifery because with a midwife or 2 midwives in the North Island, there's a strong education that can happen there with midwifery mentorship for the nurses and ongoing education so that the nursing staff do feel more comfortable. And we also heard from all the care providers and administrators around the importance of transport so that if a mom is in the North Island and in labor and something does go wrong, that the care providers need to know that they can rely on timely transport to get that mom to a higher level of care. Conversations with BCCHR right now, and they're actually coming up to the North Island with us in July to have some more discussions on how we can mitigate some of the delays that are currently happening in transport right now. And so this building block expanded inclusion criteria for low-risk delivery. So right now, women who are first-time moms are considered higher risk and sent down island or off island to give birth. However, looking at the guidelines and the evidence, parity is not a risk factor, meaning that just because mom is first time, that does not exclude her from being able to birth in a low resource site, meaning that she won't have access to cesarean section. We worked extensively with an obstetrician from Yellowknife on this building block, and he came to the island several times and spoke to the care providers and the community around risk in low resource environments and how to make those decisions and balance social and cultural risk with clinical risk. And so the last building block is the referral centers to the community. And so realizing that the referral center, so in this case Campbell River, the providers there act as a safety net for the providers in the North Island. And so we're working to just strengthen relationships between the 2 centers. And so when a care provider in the North Island calls the referral center, if they run into trouble, they're not getting a response of, what are you doing there? Like, you shouldn't be there doing this. They're getting a response of, we understand your context, what's going on, and we're here to help. And so we're just working on building those, or strengthening those relationships. And we're also using the MOM project, which is Mobile Maternity Care. So it's another project that's going on in the North Island, and it uses technology. So it's using tablet technology to link low-resource maternity, so Port McNeill Hospital, with the referral center in Campbell River and specialists there. In all these building blocks, we heard from care providers that they need to feel supported by the Ministry of Health and the health authorities for the work that they're doing. So there are only 5 1A maternity services in all of BC. There's only 5 communities that have this. And right now, the providers told us that they didn't feel explicit support for what they were doing. And so underlying these building blocks was this need to be supported by the system. So we heard from care providers that not just one of the building blocks could go ahead without the other. Just hiring a midwife is not enough. It needs to be a midwife with the increased confidence of the nursing staff, or transport, or the risk criteria. So the simultaneous development is really important. It's important also to continue the community-driven process. So we continually are checking back in, hearing from the community, hearing from the care providers on where the direction of the project should go. And then, as mentioned, the need for system support is really important. So the principle of commitment to the future, it asks questions around how are contexts of global connectivity considered in this research, and how does this research contribute to a more equitable future? So at the core of the project is a commitment to healthy moms and babies, and in itself a commitment to the future. We've heard from moms and from elders and from the community of the devastating effects and the social effects of having to travel for care. But furthermore, this project has this commitment to the future by involving students in our research. So the project has 3 research assistants who are undergrad students at UBC, and we also have 4 BC medical flex students. So I have pictures of the med students here. So these are medical students at UBC who for part of their flex project, are involved in our research. And so on the left side there's Krista Lowen, and she worked on an in-depth literature review and a policy of the risk criteria building block. So she worked extensively with the obstetrician from Yellowknife. We're on that. And then in the middle is Hannah Chester. She actually is a nurse, a former nurse from the North Island, who's now in medical school and planning to go back and practice, hopefully, maternity care in the North Island. And so she was involved in surveying and interviewing all the nurses and understanding their perspective on. But then on the right, we have Emily and Joanna, and they're working with us now, and they're documenting more vulnerable moms' experiences through a photo voice project in North Island. I really understand that. So we're excited that our future medical practitioners are involved in this research and have all had the opportunity to actually come up to the North Island and kind of see the context and understand what's going on firsthand. And another aspect of committing to the future is, as we're doing this work in Port McNeill, we started informally having conversations with other care providers in BC from other smaller communities, notably the 1A communities, meaning that they're doing maternity care, but they don't have access to cesarean section. And we realized that there's only 5 of these communities. They're Haida Gwaii, Salt Spring, Hazelton, and Invermere. And as we were talking to care providers in all these communities, we realized they all were really, their sustainability was all very threatened, all feeling unsustained and unsupported by the system. And so as we were talking, we heard of a desire for them to come together and basically share challenges and focus solutions that these communities have in common and can go forward on. And so just last week, actually, we held a community symposium with funds from the Rural Coordination Centre of BC, where we brought together 4 4 people from each of these communities. So it was care provider focused. So we brought a physician, a midwife, if there was one, and an administrator from each of these 5 communities, and discussed challenges and solutions and next steps to how we can sustain these low-resource maternity communities in BC. And that's the overview of the project. I'm happy to take questions or discuss anything that have comments or feedback on. I'm happy to talk about. So much for listening.
Thank you, Sarah. We'll go ahead and take some time for questions. Just a reminder, you can type your questions in the chat box, or please feel free to unmute.
It's Nicole here. Thank you, Kara. It was really interesting. Work Lower Mainland, we come into contact with a lot of rural communities who actually don't have a maternity program at all. So I'm curious, I don't think that designated as one, but are you familiar with any similar initiatives that are like this that are trying to help return maternity to these rural sites? Like, for example, Bella, Helsik First Nation community on the coast doesn't have a maternity program, and they have to travel to Vancouver in advance of delivery. Sometimes they're separated from their family because the delivery comes sooner, and so we see quite a lot of these problems that you were talking about. So I'd be really interested to hear about, like, what other programs that inspired you, or if you are working with any other programs, or if we can forward to trying to return maternity care to rural health in the future.
Thanks, Nicole. That's great question. So since around the 2000s when regionalization was happening, I think there's been close to 20 or 25 maternity site closures in BC, and exactly the Bella Coolas is part of that. So actually, Jude Cornelson, who's the PI on this project, would have the best insight to those questions because she's been actively involved in rural maternity care for her career. But I do know that as we look at these 1A maternity sites, these are kind of the last ones standing. The others have all closed down, as you mentioned. So how to support these? Part of it is we hope to look at a cost-benefit analysis of what is the cost of keeping these open compared to the cost that is borne on the women who are traveling, or the culture cost, the social cost when they have to leave, and what goes on with that. And so hoping through this research that when we do have this analysis of the cost savings of keeping women local and keeping them in their community, that this is, hopefully inspiring. Maybe we'll open with the health authority ideas or ministry ideas to maybe we can sustain some of these low resource maternity sites and maybe then sustain reopen. Cool.
Thank you.
Great. Another question: who represents community and community engagement?
So that's a really good question to consider when doing this kind of community-driven research, right? Because, as we're reaching out to community members, yes, we have community representatives and we have moms, but it's who's representing community and who's the voice of community, especially when working with more marginalized populations where, so that's a really good question, and I'd actually love to put it out to the group as well. If you've encountered similar questions in community-based research or just projects, and if you have any thought on that. But for us, the engagement, who represents community was a few things. One is a long-standing relationship with this community, particularly Jude Cornelson, the PI for the project, had. So she'd been working with community for years and years, so had a very strong relationship with community members and elders and hunter directors of the local nations. And so in that sense, it was an authentic relationship. She was able to hear directly from the different communities, what their needs were. And then we also had the moms on our advisory committee who were authentic in sharing with us what was going on in their community groups, their mom groups, what the talk was, what they were wanting. So we felt like we were able to hear directly from the community in those ways, in those channels, and then also being able to be up in North Island quite often strengthened those relationships as well. But I'd be curious to hear if anyone else on the line has had experiences or challenges around community engagement.
Nicole again. Sorry, I'm dominating. Our experience dealing with the rural communities on the South Coast, because we work with the health authority, we are often working through the healthcare facilities, and they are kind of like our into the community. So whether or not it's clinical staff or if it's the that are running the hospital, they're always a great resource for us to engage with the community. They're often part of the First Nation community themselves, or they have long-standing relationships there. Know that a lot of people in these communities looking for these term programs, and they end up never leaving. And so there's a lot of long-term relationships there that we try and build on the asset. But it's definitely geographical barrier is very hard for us, and it's hard for us to get up there. So we really rely heavily on the hospital staff.
Thanks, Nicole.
Sorry, it looks like we have another one. What was the capacity of the local context that you were able to engage in authentic partnering?
Yeah, so again, this is a great question. So I think CCGHR talks about, when they talk about authentic partnering, they talk about capacity of the local context. And so I mentioned the OCAP principles and the commitment to data stewardship in that way. But that is one thing that we've talked about as a project team, because allows or suggests data ownership be in terms of the community, so in the First Nations communities, but definitely in regards to capacity, that's been something that's been more difficult. It almost would feel like a burden in some cases to put that responsibility on the case. And so that's something as a project team we've talked about, how to have that authentic partnership and give over like data access control and stewardship without also being a burden to the community. So yeah, that's some of the things that we've thought through in our project and through. I'm happy to hear any other comments on that piece if other people have had similar experiences or questions on that.
I wonder everybody knows that they're still muted. I know that I've done that before, talking when I'm muted. Okay, and sorry, this is Kim again. It looks like we have one more, and I'm not sure if you've already covered it, Kira, so please, my apologies if you have. But did you identify the principles before engaging in this project, or was it already underway when you learned about them?
Thanks. Yeah, so I learned about the principles, as Nicole mentioned, the BCCI Institute in the last fall, so fall 2017. So the project had already begun. So for me, it was more of an aha moment when I learned about the principles. I saw how they align with how we were starting our project and our process anyways. So it was more of an alignment, I would say, but also it's definitely been now forefront of my mind. So as we're making decisions and moving forward with the project, I see these principles in action, which I think is exciting.
Well, great. Looks like we've covered all our questions on my end, unless anybody wants to chime in for a last-minute one. Nicole, is there anything else that you wanted to cover before I wrap up?
We just wanted to mention some exciting news. We had an initiative that came out of the BCCI to develop a graduate course that's focused on the CCGHR principles. So for those interested in learning more about the is a course planned for next spring called Practical Knowledge and Skills for Working in Global Health. It's intended to introduce practical knowledge, skills, and attitudes required in the field of global health, cover planning, delivery, evaluation, and sustainability of projects in low and middle income countries. So the special thing about this course, though, is that it's prepared with Trinity Western University, UC, and SFU, but it will be open more broadly to students of BC through the Western Deans Agreement, although the regulations done through UBC. I think it's kind of like a for myself, but also just something I think that a lot of students will be really excited about. That's coming up in May 2019. So once we get further information about it, we'll post it to the BCCI website and probably to the SIP Facebook group and advertise through all the normal channels at that time. Barb would be able to join us from Geneva, so I could put her on the spot, but she's unable to make it. So that's just something I add in really quickly.
That sounds really exciting.
I think so.
Great, and thank you to everybody for joining us today. Thank you, Kira, for the wonderful presentation, and thanks, Nicole, for organizing everything. And we appreciate all of you. And thank you, Ben, and we will see you next time. Stay tuned for the next event.
Thanks so much. Thank you, everyone.